Good morning, everyone. I'm Kimberly Chalia with PHCA. Thanks so much for joining us for today's webinar. A few quick updates to share before we get started. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1 continuing education credit for all PHCA members in attendance. For those who provided a NAB number, credits will be uploaded within the next 2 to 3 weeks. As we begin today, all attendees will be in listen-only mode. Please feel free to submit your questions via the chat icon at the bottom of your screen, and we'll make sure to answer as many of those questions as possible at the end of today's presentation. And now I'll turn it over to our presenters. I think Maureen's going to kick things off.
Hello, everyone. My name is Maureen Mulvihill, and I am President and CEO of Actuated Medical, and I'm very honored to be here. And I hope that we'll be able to explain a lot more about clogs and how not to have clogs in your feeding tubes. I'm joined by Paula. Paula, do you want to introduce yourself? You're muted.
Hi, I'm so sorry about that. Hi, everyone. I'm Paula. I'm a nurse here at Actuated Medical. I have worked in long-term care, acute care, and in the research world, and I'm happy to be here today and be able to help with answering any of the questions you have about the presentation.
Abby?
Hi, I'm Abigail D. Lellis. I am a clinical education engineer and an R&D engineer for Actuated Medical. I do a lot of marketing and sales for TubeClear and then biomedical engineering on the side as well.
Great, thank you. All right, so let's get this going. If I can get my cursor to go. There we go. Just to show you guys, I am not a clinician, therefore I'm giving my opinion. Something maybe I read from literature and we're making quotes to that. So, and I'm also not speaking on behalf of Actuated. So if there's anything that I say here and you're going to change practice with your patients, please consult the physician or the healthcare practitioner for that specific patient. And then the other disclaimer or disclosure is I am the TubeClear co-inventor, and I'm also the president and CEO of Actuated Medical. Okay, so what we want to do is we want to really talk about how clogs form, how to identify them, and then how to figure out that we don't want them anymore, like what works and what doesn't work. So we want to understand the importance of proper tube care, prevention in order to minimize these clogs. And then we want to compare different techniques that people have been using for a long time, or maybe just recently, on how they're clearing their feeding tubes. So we want to really focus on tube patency and how it's so much better for your patients. Just a little bit about Actuated. So Actuated Medical is a product innovator. The TubeClear system is our first product we got on the market. We're located in Bellefonte, Pennsylvania, so right in the middle of the state. We're about 6 miles from Penn State's main campus. We are ISO 13485 certified, which means we can manufacture our medical devices, and we are certified a woman-owned small business. So that's kind of a little bit background. This is my incredible team. We have a 20,000 square foot facility. We have R&D, we have manufacturing, we have our own machine shop. So setting the stage for what we're talking about. Feeding tubes are what is necessary for patients that have a functioning lower gastrointestinal tract, but they're unable to orally ingest nutrients or medication, or they're at risk for malnutrition. And we know with the elderly population, that's a big problem. Conditions that necessitate having a feeding tube, or somebody that might be premature, somebody with this gastrointestinal dysfunction, failure to survive, cancer treatments, burns, different people that just need to have that extra nutrition. These are actual clogs. So people say when a feeding tube clogs, they're like, what do they look like? Well, these are actual clogs. So when we started talking to nurses about, we have a device that clears feeding tubes, they started sending us photographs. So these really ugly, and I say like ugly macaronis, are clogs that have been in actual feeding tubes that they've sent to us. If you think about clogging happens about 25% of the time. So if you're looking at there's 7 million feeding tubes, there's about 1.8 million feeding tube clogs that clinicians are dealing with. just also setting the stage to this. So this was actually a person who lived in Altoona. That's also central Pennsylvania. He did not know about the TubeClear system. His feeding tube clogged on a holiday weekend. His parents had to drive him 2 hours to Pittsburgh. They didn't have anyone, because it was a holiday weekend, to clear that feeding tube. They had to admit him to UPMC, and he sat there for 4 days waiting for someone to change his feeding tube. So during those 4 days, he deconditioned, and his family didn't go on their family trip that they had planned to go camping. So the idea of feeding tube clogging is significant for the person, the patient, for the caregiver, and also the family. This is another case where this person had a GJ tube, and their tube was clogging often. And it actually clogged 3 times in 1 month. But the result of that is what we really want to stress, is because they weren't getting that nutrition, they were getting bed sores, they were dehydrated, they were missing the nutrition, and they were also missing their medication. And so for the family members that were taking care of this patient, it was a huge issue. And he says, I spent 8 hours trying to clear the tube using a combination of warm water, Coca-Cola, meat tenderizer, salsa, and nothing worked. And that's what we're here today to talk about, is better ways to keep these tubes patent so that we're optimally delivering the medication, nutrition, and hydration to these patients. Now we did a survey, or Oli did a survey, and the survey was about 180 patients that were, or caregivers that were in the home care setting. And so if you think about, there were about 81% of those reported that they had experienced clogs, and 39% of those people responded that they had to have a tube replacement. So the idea of having a mechanism that clears tubes reliably in the home or in the long-term care facility is what is a better option than transporting your patient to the hospital. And so the question we asked them have you ever had a tube replaced because of a clog? And that 39% said yes. This is another study that we were looking at, and we were looking at feeding tubes and how they clog off over time. So what we were hearing when we were talking to clinicians out in the field, they said, oh, a nasal gastric tube, after about a week, it gets a little bit sluggish, and about 2 weeks, it kind of clogs off. So we really wanted to understand that. And so we ran a bench study. And what we showed that is, if you had an 18 French feeding tube, you have material buildup over time. And then the tube's no longer 18 French, it's 14 French, which decreases the flow rate by about 50%. So think about that. You think you're delivering, 5 cc's, but you're actually only delivering 2.5 cc's. So your patient is not getting the optimal amount of nutrition and medication and hydration that you think they're getting. So the other parts of this is we wanted to look at that syringe force. And so this was a poster that was presented at Aspen this year. And if you look at the syringe here and you look at the fingers and how much pressure those fingers are pushing on that syringe, when there's no clog, so it's just fully open, you just push with your thumb and it goes in with no pressure. But even just a small layer, so you're looking right here, and with that syringe, it's really hard to see the difference between fully open and this partially or a sluggish tube. But when it's fully occluded, almost fully occluded, where we have 2 layers here, you have to push really hard with your thumb. And then to the point when it's fully occluded, your thumb, you can't move it, right? So the idea of thinking about how much pressure am I using with that syringe as I'm flushing my tube is really indicative of how clogged the tube is, or how clogged the tube is becoming. And this was really important to us, and this paper was very well received, because a lot of people aren't thinking about the tube starting to clog off and the fact that we're not optimally delivering the nutrition, medication, and hydration to patients. So if we talked about this, so we know that there's about 7 million feeding tubes that are used annually And we know that feeding tubes are providing the medication and nutrition and hydration that's life-sustaining. So we often compare it to a PICC line. Everyone's like, don't lose the PICC line. Don't, because it's so important. You got vascular access. But a PICC line's delivering the medication, the nutrition, and hydration just like a feeding tube. So the idea of keeping that feeding tube fully open so you're optimally delivering that hydration, that nutrition, and that medication. One of the other parts here is so the references. So several of the statements we make are referenced, and at the end of the presentation are all of the references. If anyone's interested, we can send you those. But anyway, one of the references stated that tube patients are malnourished by about 50% of the time. So think about that. The feeding tube patients in your facility probably are not getting or achieving the caloric goals they should be achieving. And that could be because the tubes are starting to get, the inner diameter starting to get smaller and smaller as that material starts building up on the walls. And the other part to this is that a feeding tube patient that's feeding tube patients that's receiving nutrition this way, only about 14% of those patients are receiving 90% or more of their caloric goals. So the idea is that, like, once again, as those tubes are getting smaller and smaller on that inner diameter, they're just not getting the nutrition that they require. We also know from literature that feeding tubes clog, or as they aren't functioning properly, they're getting smaller and smaller, that it's the malnutrition is this big problem. And we also know that malnutrition is very expensive. So not only are the patients starving and they're dehydrated, but the cost of malnutrition is significant. And it's been projected to be over $30 million. So that's a huge number, and a huge number that we need to think of as a country as we're taking care of these patients. So as we're looking at causes of clogs, so first could be just the narrow diameter. Then the other one is insufficient flushing. So you want to flush in between each of the medications that you're administering. And then, of course, improper medication administration, and then mixing medications, and then flushing with acidic juices is also a problem. And I'm going to hit each one of these in the next slides. So that narrow diameter. So what you want for your patients is you want the largest diameter that's comfortable for your patient. So you don't want to put an 18 French nasal feeding tube in your patient for a long time, because that's very uncomfortable going through the sinus passage. But you also want to think about, if I get a super small diameter, I'm going to get a lot more clogging because it's just a really small diameter. So one facility that we talked to, they were using an 8 French feeding tube and they had a lot of clogging. And when we talked to them about it, they went back to a 10 French and they reduced their clogging problem significantly. The other idea is when you're working with PEG tubes, if you put a jejunal extension into those tubes, then you can get better or less clogging. Other preventative measures are insufficient flushing. So you want to flush before you administer the medication and then after you give the medication. And then the other part to this is if you have a grinder. So a lot of people say, oh, I have a mortar and pestle, and I put them in a mortar and pestle, and then I take that ground up medication and I put them into the feeding tube. But we've found that by using a grinder, you can get much finer particles, and therefore they go through the feeding tube much easier. With this also, we want to talk about, you want to separate everything with water, and that's the medication and the formula. And so you want to flush often. So you flush, give the medication, you flush, give the medication. The one other point we want to bring up is that syringe force. There's a lot of problems now where people are using the end-fit connector connected with the syringe, and they're taking the syringe and they're pushing really hard. So it goes back to that thumb pressure that I was talking about on that other slide. And they're pushing, so we call it like a power flush, and they're actually causing tubes to break. So what we want to tell people is, if you're looking at your syringe here, and this is actually an example of a 60 cc syringe, and you can see these lines. So each one of these lines is a milliliter. You really, if you're pushing on your tube and you're like, it's not moving, it's clogged, you don't want to make the little gasket move more than 2 or 3 of these lines. So you don't want to power flush. You just want to kind of push 2 lines and hold it there and see if your tube is clogged. You don't want to just exert a huge amount of pressure because, like I said, you can cause those tubes to break. Preventative measures for the clogging, once again, improper medication administration. So with each medication, you want to deliver them separately. You want to crush them. As I said, we use a pill crusher, getting a really fine powder. You want to dilute that powder in the water, and that's what you want to put into the feeding tube. And then when you're done, you want to flush again. Then you want to take the second medication, the next medication. You want to grind it up. You want to flush with water. You want to put the medication in water. You want to flush again. And then you want to use the syringe and flush again. So you want to flush, dilute the medication, put the medication in, flush again. And as I said, you want to grind it up as small as you can so you don't get big particles in the feeding tube. The other part, and this is a paper out of Sloan Kettering, is they say do not, so we said recommend, right? They said do not administer enteric coated or extended release into feeding tubes because that coating is so important to the way those medications work. But once again, if the pharmacist or your doctor says that you're supposed to be delivering these enteric or extended release, really talk to them about this and make sure that's the proper way that those medications should be delivered. Now back to mixing medications together and then mixing them with formula. So formula sometimes has the effect that it interacts with the medication and it causes more clogging. It causes like a cement. So the medication mixes with the feeding formula and then it just becomes a really cement type mixture. So that interaction of the medication and the feeding formula is really unknown until you put them together. And so the idea is to keep the feeding formula separate from your medication delivery. So when you deliver you would do the water and then you would do the feeding formula, you would flush with water, then the medication, and then flush again. So just remember to keep things separate. Keep your medication separate, keep your feeding formula delivery separate, and flush with a lot of water if your patient can tolerate the water. Then there's also people say, oh, you should use acidic things that help with clog or help with declogging, right? So sometimes they say Coca-Cola, sometimes they say some sort of acidic juice. When I was talking to somebody from Michigan, they were like, it's Verner's, which I guess is a ginger ale from Michigan. But anyway, so everybody has their ideas. But acidic medications, acidic juices are not good. There's a lot of literature out there that shows that it actually can cause further clogging. And also, if you're working with things with a lot of sugar, you're putting a sugar coating on the inside of your tube, and that sugar coating can cause issues also. This is actually an illustration that we did for feeding tubes. It's more like the hospital environment, but a feeding tube is a lifeline to so many different departments in the hospital. So in pharmacy, in the ER, in the ICU, in the GI. So many people are impacted when a feeding tube clogs in the hospital. The system just breaks down. We know that when a feeding tube's clog, that patients are not getting their medication, and that's even a sluggish tube. So if you have that buildup over time, the medication you think is getting delivered may be just collecting on the inside of the tube, so they're really not getting that medication you think that they're getting. But if you look at their 7 million feeding tubes at a 20% or 25% clog rate, we're talking about there's 1.8 million feeding tube clogs that caregivers are dealing with all the time. This is actually a paper out of Harvard University, and it showed that by like interrupting enteral nutrition, so it could be a clog or it could be physical therapy or some reason you stop the delivery, it actually extends the time that the patient is in the hospital. So if you think about it, in the ICU where it's $6,000 a day, adding a day and a half to the ICU will take your cost up about another $10,000 to take care of that patient. So the idea is we don't want to interrupt enteral nutrition. We want it to be delivered on time, on schedule, as prescribed by the caregiver or the physician. There's also for nasal enteral tubes, there's a risk when they place a nasal enteral tube. So you go through the sinus passage down the esophagus about 2% of the time. So 100 times in the United States, it is malpositioned into the trachea, which means now you're feeding into the lungs, which it has about 100 patients a year in the United States pass away from this issue. So that malpositioning we don't want. So a lot of facilities will confirm with X-ray that they're in the GI system, or they have some sort of indicator method. But our focus really is, let's keep the tubes in place. We know they're in the proper location. Let's not change them. And then the other risk to changing a tube is anesthesia. If it's a surgically placed tube, a GJ tube, or a G tube, and then that risk of infection because it is an invasive procedure. Transportation, we threw in here just talking because this group, you're probably thinking about this. So you have the patient, they're in your facility, they get a clogged feeding tube. You have to put them in the ambulance or sit them in transport, and you need to transport them to the facility. So you may not get reimbursed for the bed that day because when they get to the hospital, they may have to be admitted. There's readmission cost, and then your facility staff time. So we had a facility out in Utah, and when they had a clogged feeding tube, not only did they have to send the patient to the hospital, but they had to send the respiratory therapist. So now they lost that respiratory therapist for the day as that team member was with the patient in the hospital. And then, of course, there's risks of complications. So that's infection risk. As you transport someone from one place to another, we all know that the risk of infection increases. Going back to replacement. So a nasal gastric placement is one of the most painful procedures in the ER. So when you think about you're putting a tube through the sinus passage, down the esophagus, and into the stomach, then those tubes are very painful. And then for the surgically placed tubes, those tubes are, you have to have anesthesia, you have to have OR time, all those different things, but it's also an invasive procedure, which has then recovery time. Replacement is also costly. So if you have a GJ tube, the average cost to replace a GJ tube is somewhere around $5,000. And that's OR time. The tube is very expensive. You have to have a GI doc or an IR doc do that procedure. And so it's costly. A nasogastric tube, as we already talked about, is probably about a $15 or $16 tube, or maybe it could be 40, depends which one you buy. But anyway, so those tubes don't seem like they're expensive, but once they're placed at bedside, then you need to confirm with X-ray that you're in the right location. And so that is somewhere around $200 to $400 for a nasogastric tube replacement at bedside. And then back to that same illustration I had on the other slide is for the extended care of the home care. When that tube is clogged, you have that transportation, you have that empty bed you might not be getting reimbursed for, you have readmission costs, facility staff time, and then the risk for complications. There's different changes of things here. Now we're talking about how do we declog these devices. So lots of papers out there, people talking old school, let's use juice or soda. Sometimes that's water and syringe. There's enzymes, there's brushes, and then there's an active mechanical device. So those juices, so somebody will say, oh, I use Coca-Cola, or if you're in Michigan, use Verner's, or they use cranberry juice, or they use meat tenderizer. All these things are not that effective. If soda worked, water would have worked. And soda's bad because it puts that sugar layer on. It's acidic, which can cause clogs further down. And that goes back to the next statement. So the acidity, or that pH change, may cause the proteins to participate, and then you have worse clogging in the future. This is actually the standard practice most places use. They have a syringe, and they use that syringe to flush the water. And I'm just showing you here that when the tube's fully open, it's just easy to push with your thumb. But as the tube gets more and more clogged, you have to put more and more pressure on your thumb to get the water to go into the tube. And eventually you can't get in. And then we go back to people doing the power flushing, which is now causing tubes to break more frequently. So what you don't want to do is you don't want to push with your thumb and make that, we'll say that diaphragm here go more than 2 or 3 of those milliliter lines, because you don't want to power flush these tubes. There's also enzymes out there. So there's Clog Zapper and there's Viocase. And these work They're indicated to work on the feeding formula or protein clogs. They're not indicated for medication. And we all know that clogging is really one of the main culprits for clogging is the medication that's going down these tubes. And so these aren't even indicated for that. And that's probably why their efficacy is not so high. But these enzymes also can interact with medications, and they also have, at least the clog zapper has a papyrus. So if you have a patient with a papyrus allergy, which I think is in the same family as a banana, then you can't use that on those patients. So there's like a food allergy concern there. There's also brushes. So the brushes are great. You put them in, you twist, and maybe they'll open up the clog, maybe they won't, but they only work on short tubes, so up to about 14 inches in length. So, and we've also heard of, as you put them in there, if they get caught on the clog too much and you twist too hard, you might break them. But they are very inexpensive and they work on very short tubes and very, I would say, softer clogs. And then there's the active clearing method or device, which is called the TubeClear system. And TubeClear is a medical device. It's FDA cleared for adults, and it's indicated for nasal gastric tubes, nasojejunal tubes, G tubes, J tubes, PEG tubes, GJ tubes. And it basically goes into the tube and it uses mechanical motion to break up the clogs. This is a comparison that was done by Penn State University, and it compares the active mechanical device to the enzymes to the water. And it showed the efficacy of the mechanical device was 93% compared to 33 and 20% for the enzymes in the water. And the time to clear is significant here. So when you use TubeClear, it goes in, it breaks up the clog, and you're done. But with the enzymes, you put them in, you have to let it dwell for 30 minutes. You come back in, you let it dwell for 30 minutes, and you see if you can get it cleared with that. And the same with the water. You put the water in, you let it dwell. You have to remember to come back and try it again to see if you can break through the clog. So then if you look at estimated nursing time for that 8.5 minutes, we put it against probably $50 an hour, comes out to about $6 to use TubeClear, but the enzymes are about 80 and the water was about 70. And if you look at that efficacy piece, like the enzymes didn't work, you still got to do something else. The water didn't work, you still got to do something else. So you have to look at the cost of the care and the time of your staff. This is actually a study. It's a white paper written by Bob Buckley. He was a nurse at Neurorestorative in Utah. And he had in 1 month, he had a patient that had the feeding tube clogged twice. And he was able to use TubeClear in their facility rather than sending them to the hospital. And so there was no transportation costs, no tube replacement costs, and no need to lose that respiratory therapist for the day. So he showed that he saved $4,000 per clog by just using TubeClear at bedside in his facility. And key statements to his white paper were it was simple to use, proven technology, effective in clearing the tubes, cost efficient, provided better resident comfort, and provided confidence in the provider's care. It showed that they were able to clear the tube at bedside without having to transport them to the facility or calling the family and saying, we're transporting your loved one to the hospital. This is another palliative care case, and this patient was a man who was about 90 years old, and they were the medications they were putting down his tube, his tube was clogging every 2 weeks. And so the family found the TubeClear system, and they had a nurse come in, and that nurse was using it often. And they kept that tube, rather than having it changed every 2 weeks, they kept it in for 3 months until he passed. So the idea was by using TubeClear, they were able to deliver his medication on schedule as prescribed. And he was able to stay in his home where he was very comfortable. When he would go to the hospital, he would have delirium and he would decondition because he was blind, hard of hearing, and things like that. So by being able to use this device at bedside, it was much better. This is another home care patient, a cancer survivor. And this is also a poster that was presented at the National Home Infusion Association just a couple weeks ago. And the device was successfully kept the tube open. It was successfully resolved all the clogs and kept that patient from not having to go to the hospital to get it changed. But the one remarkable thing here for us is the fact that she felt comfortable after having TubeClear that she could go on vacation with her family. Up to this point, she was afraid to go on vacation for fear she would get a clog on vacation and she would have to go to a hospital that she wasn't comfortable with. And so she was very excited by that. This is my incredible team. As you met Abby and Paul at the beginning, and I'll be glad to answer any questions.
And I'm looking at the chat. I don't see any questions, but as always, feel free to submit your questions if you have any. And if not, Maureen has her email. Maureen, do you have your email listed?
Yeah, it's on that slide. It's right here. You can do clinical education at actuatedmedical.com if you have any
Great.
questions about the product.
And then, as always, you can email Maureen or myself. We're happy to answer any questions that might surface after today's session. And I appreciate your time today. And thank you so much for this valuable information.
Thank you.
Thanks, guys.